Dear students, the topic for my current lecture is deficiencies of micronutrients in children. This topic is covered in 2 lectures. Today we will take the first lecture. I am Professor Akmal Laeeq from the Pediatric Department of Akhtar Saeed Medical College, Lahore. The objectives must be set forth at the beginning. So, before discussing the subject at length, let's review the objective. I want all of you to understand that micronutrients are important, but why? And secondly, what are the different types of micronutrients for children? The second objective is that we all should know the basis, the physiologic basis, the physiologic functions of various micronutrients, especially with reference to children. We also should be familiar with the causes, clinical feature, the diagnostic criteria for each micronutrient in children. We should understand clearly how should each deficiency of micronutrient should be managed, and of course the prevention is our topmost priority, and we should all know the strategies, the methods to prevent the micronutrient deficiency at community level. So first, let us learn what is a micronutrient. This single word is in fact representing 3 important human requirements. There is vitamins, minerals, and trace elements. They are called micronutrients compared to macronutrient. Macronutrients are proteins, carbohydrates, and fats, while micronutrients are always consumed in very small amount on daily basis. Approximately less than 1 gram is consumed per day. Now these do not require any change. First, they are essential. They cannot be synthesized by the human body, and they are absorbed without any modification. They are absorbed as such without any change. They are not meant to provide energy like energy derived from carbohydrate, fats, and proteins, but their major function is as a coenzyme, as a catalyst, as a hormone in various important vital body functions. Some micronutrients like calcium and phosphate have an important role to play in the body structure, like bones, like joints, like teeth. So, but majority are working as coenzyme, catalyst, and hormones. Vitamins was a word coined almost 100 years back, and it stands for vital amines. These are basically organic substances which are broadly of 2 types: fat soluble and water soluble. Fat soluble are vitamin A, D, E and K, and water soluble are members of B complex family, vitamin C and folic acid. The minerals, that word is used for calcium, phosphate and magnesium, which are primarily making up the bony structure, and the trace elements like sodium, potassium, like iodine, like iron and copper, like zinc, like manganese, and the newer ones like fluorine, selenium, chromium, and sulfur. All of them are labeled as trace elements. This again what we have learned, that vitamins are essential in the sense that they need to be supplied from outside, obtained from the diet, and cannot be synthesized inside the human body, and they are essential organic substances for many vital physiologic enzymatic functions in human metabolism. They work differently like hormones. Just like vitamin D, that is synthesized at one place, then activated, then have a different distant site of action. Like vitamin A and vitamin E, which are antioxidant to help neutralize different oxidant compounds synthesized during normal metabolism. Vitamin A also functions as a cell mediator of various signals and regulates cell and tissue growth and differentiation. Many vitamins work as precursors for enzymes, cofactors, biomolecules, coenzyme, catalysts, and ultimately essential to carry out the normal metabolism in human tissues. Now come to each vitamin one by one. In my first lecture, I will be talking about fat-soluble vitamins. Vitamin A is fat-soluble. This means that a fat absorption is must, because fats will carry vitamin A along with it concomitantly. When there is fat malabsorption, there is bound to be vitamin A deficiency. Now, vitamin A is derived from two different sources. One is vegetable, like carotenoids, like beta carotene, and then converted inside the human body into active vitamin A. And it can be preformed vitamin A from animal sources. We all understand from knowledge of physiology that vitamin A is an essential component of the retinal eye pigment rhodopsin and iodopsin, which are essential to carry out the functioning of rods and cones, and in their absence there is night blindness. Patient has difficulty in having a vision at night. Another important function of vitamin A is that it helps to maintain the structure and functioning of the lining of human tissues like GIT, like respiratory system, like skin, like eye, like kidneys. So if vitamin A is deficient, the normal skin and mucosal barrier function of these tissues will be gone. and there will be many problems will follow. Vitamin A is very important for proper functioning of immune mechanism in human body, and in its absence the patient develops recurrent infections, especially in children. Hence some people would love to call it as anti-infective vitamin. The recommended daily amount required is around 400 to 600 microgram per day. Now this shows the different sources of vitamin A. There are animal sources like meat, egg, cheese, fish, which give a preformed vitamin A, and there are vegetables, especially the yellow-orange vegetables like papaya, melon, mangoes, peaches, apricot, carrots, which produce carotenoids, and then on injection they are converted to active vitamin A. It has been estimated that it is the most common nutrient deficiency in developing countries, especially in children below 5 years. Up to 50% of children, they are having subclinical deficiency of vitamin A. We understand that it manifests as problems with the eye, especially loss of night vision and xerophthalmia. But equally important are other effects of vitamin A deficiency like gut infection, respiratory infection, dry, scaly, hyperkeratotic skin, decreased immunity, anemia, apathy, mental slowing, poor growth in these children, and in some cases signs of raised intracranial pressure with sutures separated white fontanelle. All these are seen in different aspects of vitamin A deficiency in these children, especially below 5. Now this shows you the different clinical features of eye signs of vitamin A deficiency. You see dryness of conjunctiva, conjunctival, white foamy spots, dryness of the cornea, and finally corneal ulceration, keratomalacia, and perforation and maybe complete loss of vision. WHO has categorized the severity of vitamin A deficiency into these clinical types. To begin with, earliest may be night blindness, poor night vision, nyctalopia, followed by dryness of conjunctiva, followed by bited spots, followed by dryness of cornea, and then corneal ulceration, small to big, and then corneal scar formation, and finally maybe xerophthalmia of the fundus. Vitamin A deficiency is not limited to one or two or occasional cases, but it has been said to be more than 50% of children in Pakistan below the age of 5 years have been shown to have vitamin A levels far below the optimum levels. Similarly, almost 70% of pregnant and lactating women have vitamin A deficiency in various field surveys. You have a vast majority of subclinical cases compared to the clinical cases of xerophthalmia and night blindness. So that is typically what we call as iceberg phenomena, in which a very small part of the iceberg is seen outside the water level and the big chunk is always hidden below the water level. So based on the finding, WHO and the UNICEF have started a national vitamin A supplementation program for all developing countries, especially in the South Asia and the Sub-Saharan Africa. It was launched in 1999, and children between 6 months to 5 years of age were given 2 doses of vitamin A per year. They were given orally. The capsule was punctured and the drug was administered orally every 6 months. Observed benefits have been important, like a significant reduction in the death rate due to diarrhea, up to 28%. And vitamin A supplementation also affected the all-cause mortality up till 12 to 24%. So this program is still continued in our country, and children are given vitamin A every 6 months along with National Immunization Day. However, one should also attempt to improve the child's diet as well by asking the parent to give him green leafy vegetables and animal protein for increased uptake. We have just learned that vitamin A supplementation program has been launched. The target population is children from 6 months to 5 years. Below 6 months, no vitamin A is given. So in the first 6 months of life, in the second 6 months of life, children get a dose of 100,000 units once, and children from 1 to 5 years get 200,000, that is 2 lakh units of vitamin A every 6 months. The benefits have been exemplary, that the children receiving vitamin A supplementation are shown to have overall reduction in mortality up to 23%. If they get measles, the mortality is at least reduced by 50%. And if they get diarrhea, the mortality is reduced by 40%. Coming to the next vitamin, fat-soluble vitamin, because of its essential role in formation of bones and teeth, hence is very vital regarding children's health. Now, why should patient develop vitamin D deficiency? First thing is that the mothers do not take adequate vitamin D. So before the baby is born or even in intrauterine life, the mothers themselves are vitamin D deficient, especially those who are multigravida. The babies are not exposed to sunlight, neither the baby nor the mothers. So the synthesis is very poor. They don't take vitamin D orally because we all know that vitamin D is very poor in the breast milk and is not adequate. So babies who are exclusively breastfed for more than 6 months, 1 year, they frequently have vitamin D deficiency, especially if there is fat malabsorption, chronic persistent diarrhea, cystic fibrosis, celiac disease, or patient having a liver disease, renal disease, or certain drugs which affect its metabolism. All these are risk factors for vitamin D deficiency. Now, what is rickets? Rickets is basically defective mineralization of bones and teeth. Now, why it happens? It happens because of either lack of vitamin D or calcium or phosphate. But the most common cause remains vitamin D deficiency. Ricket is always seen in the growing bones. Growing means till there is union of epiphysis. After that, there is no rickets. So, the bone, especially long bones, have growing bone ends, especially like the wrist, the lower end of radius and ulna, and around the knee joint, lower end of femur, and upper end of tibia and fibula. They are the growing ends of bones. If you perform the biochemical testing, you will find that there is deficiency of calcium, phosphate, and raised alkaline phosphatase level and very low 25 hydroxy vitamin D3 levels. In selected cases, yes, we go for other investigation like urine complete examination, like renal function test, because kidney is an important role to play in vitamin D metabolism. Blood gases might show feature of renal tubular acidosis. Liver function test important because in situation there is decreased vitamin D hydroxylation at the liver level and parathyroid level is frequently raised in rickets. Now this tells you how vitamin D is synthesized. Under the effect of sunlight on the human skin, 7-dehydrocholesterol is converted to cholecalciferol, which is D3. So it first goes to liver for 25 hydroxylation and then goes to kidney for 1 hydroxylation, and ultimately the active form is 125 dihydroxy D3. That is the active form. We can take orally through our diet vitamin D3 from the animal source like fish and meat, or like vitamin D2 from the vegetable source. But it again has to go to liver first, then kidney to become an active vitamin D. Active vitamin D then start acting on the gut for calcium absorption, on the bones for calcium deposition, and the kidneys for absorption of calcium. These are the important sources of vitamin D shown here, like fish, like milk, like fish, liver oil, seafood, eggs. All of them are important. Important thing to note is that the human milk, the breast milk, is quite deficient in vitamin D. Only 30 to 40 units are present in 1 liter, which is quite inadequate. So we need supplementation even in the first 1 to 2 years of life. Rickets is very well known to all of you. You must have seen number of patients, but the important features are there. You start examining these children from head to toes, and you observe many features, like a big head with widened sutures, frontally with a late closure, with very soft skull bones as craniotabes, with frontal bossing, box-like head, with poor dentition, delayed dentition, dental hypoplasia, with chest deformities like pectus excavatum, carinatum, Harrison sulcus, and rachitic rosary. At the back you may find kyphosis. Then the wrists are swollen, wrist and the ankles, they are swollen because of the widening of the epiphysis, and the legs are showing bowing in certain cases. A typical X-ray of the wrist showing changes of rickets like cupping, fraying, splaying at the ends of radius and ulna, and the delayed appearance of epiphysis center in this area. Again, these photographs show the typical clinical features we see in our practice. A child showing enlarged, prominent costochondral junctions, has rachitic rosary, widened wrists, bowing of legs with a knee joint deformities, and chest deformity, having a pigeon-shaped chest deformity due to vitamin D deficiency. How do we treat them? Nutritional rickets requires treatment on 2 different ways. The most widely practiced and effective method is using 2 lakh units of vitamin D3 in an injection form in a vial, to be either given orally or injected intramuscular, given for 2 to 3 doses, or we can offer the patient a daily therapy of vitamin D in a dose of around 4 to 6,000 units per day, but to be continued for 4 to 6 weeks. Patients having poor compliance would benefit by our first method of treatment. It is very widely used and effective and practical. Now this is followed by use of vitamin D 600 units per day for a minimum of 3 to 6 months. We should also ensure that patient is having adequate intake of calcium containing diet like milk and the dairy products, meat, eggs, fish, and adequate sunlight exposure. In follow-up, we perform a repeat wrist X-ray to show the signs of healing in the form of calcification at the epiphyseal sites. If the patient has no signs of healing or improvement despite 3 doses of vitamin D given, we call it as vitamin D resistant rickets and need further workup to know the cause. Some patients are having very severe vitamin D deficiency causing severe hypocalcemia, and they come to us with tetany. They require IV calcium for initial 2-3 days, followed by oral calcium and vitamin D. Our third important fat soluble vitamin is vitamin E. It is an antioxidant and its technical name is alpha tocopherol. Now, this vitamin E is derived from various vegetable oils which are fortified, multiple seeds, nuts, green leafy vegetables, and margarine. So whenever there is fat malabsorption, there is concomitantly vitamin E malabsorption and deficiency. Patient having a obstructive liver disease also get vitamin E deficiency, especially premature babies. They are victims of anemia because of hemolysis, thrombocytosis, and frequently having ataxia due to CNS neuropathy. The recommended daily allowance is around 5 mg per day, but it all depends on the amount of intake of polyunsaturated fatty acid, maybe up till 10 milligrams. And if patient has vitamin E deficiency, when you suspect, you can manage that by giving him 25 to 50 units of vitamin E per day for 1 week and then continue with the RDA. The fourth vitamin in this series is vitamin K. Again, fat soluble, so patients having fat malabsorption, they do not get adequate vitamin K. You know very well that vitamin K is essential for clotting pathway because it is involved in synthesis of factor 2, 7, 9, 10. 2, 7, 9, 10. Factor 2 is involved in both the common pathway. So vitamin K is derived either from the gut bacteria, but again, the newborn babies do not have gut bacteria. Their gut is sterile, so they don't get vitamin K. They only get it from the mother. So vitamin K is an important cause of bleeding tendency in neonatal period, where you get a special name called hemorrhagic disease of newborn. Hemorrhagic disease of newborn. The disease typically manifests in children, in babies between 1 to 14 days after birth. The breastfed babies are more susceptible because the breast milk has a very poor source of vitamin K compared to cow's milk. Some children get vitamin K deficiency bleeding after 1 month. It can be due to malabsorption of fat, like hepatitis, like liver disease, like biliary atresia in these babies, and the disease may come after 1 month, 2 months, 3 months after birth. As a principle, all babies after birth should get vitamin K 1 milligram intramuscular or orally. And if the patient starts bleeding in the newborn period, we should immediately give him vitamin K 1 milligram at any site of bleeding. And if it does not stop, we can use fresh frozen plasma to control the bleeding. Now, this is a newborn baby who didn't get vitamin K at birth. was breastfed and thus developed vitamin K deficiency and hemorrhage disease of newborn. So he is showing you multiple bruising spots on the skin, but he can bleed from other sites like hematemesis, like cut umbilical wound, like circumcision site, and like CNS. So there can be any site, whether the skin or a mucosal bleed in this baby, and this can be easily preventable by 1 milligram vitamin K given intramuscularly at birth to all live births. I think we're going to stop it here. We have discussed 4 important fat-soluble vitamins, and in our next lecture we will discuss the water-soluble vitamins and minerals and other micronutrient deficiencies. Thank you very much for your kind patience and listening.